Hey, welcome to OsteoBoston, the solution seekers for better bone health. If you're with us tonight in person, a big welcome, and we're so glad for you to be here, and we hope you stay and wait till after our speaker finishes for the second half of the program. And if you're watching this on YouTube, welcome. If you like what you've heard tonight, please give us a thumbs up, and that way we can plan our content better. And if you want to see more programs like this one, then why not subscribe to the channel? So thank you. And I get to welcome the fabulous Joanne Fagerstrom, and we're very excited about that. And I'm going to ask all of our live participants to turn their videos off. Welcome, Joanne.
Thank you so much. I'm going to go ahead and share my screen here. And hold on a second. Participants, wait a minute. Sorry. Oh, there we go. Okay. From beginning. Okay. So thank you so much for having me. I'm thrilled to be here. I'm always thrilled to share everything that I have learned along the way with as many people as I can, because what I have found more than anything else in the world of osteoporosis and low bone density is that there's so much fear and misunderstanding about so many things that I just feel that the most important thing is that we can empower ourselves with information. Even though I was able to turn around my osteoporosis diagnosis, which, by the way, I was completely shocked to get that news. I was 50 years old at the time. That's before they changed the regulations for when you get your first one. I'm 68 now. Anyway, I really was so surprised, and you know, my doctor immediately wanted me to go on Fosamax, and we struck up this deal that I was just going to look into a few things, and we would meet again in a year and see if I could change anything. And a year later, we had another Dexa. The numbers were basically the same, which we saw as a victory. And then a year after that, it had gone into the low bone density range. So a lot of people asked me what the numbers were. It was the T-scores were minus 2.5 in my hips and minus 2.7 in my spine. So with no further ado here, let's just jump right in. I know that many or all of you are very savvy about this diagnosis. You've been privy to many wonderful presentations, but I think it's really important to lay some basic groundwork. So osteoporosis, it literally means porous bone. The density and the quality of the bone are both reduced. The bones become more fragile and porous over time, and that's when we run into the greater incidence potentially of fractures. And you can't feel your bones getting weaker, so it's often called the silent disease. Many times people don't realize that that they have this condition, which I don't call a disease. They have this condition until they have the unfortunate incident of breaking a bone. So Murshid Sinaki is a physiatrist. It's like a rehab doctor at the Mayo Clinic. She's the author of many, many research papers. It's just fabulous to read her work. And I just loved her definition of osteoporosis, which I won't read. You can read it on your own, but it really is so much more holistic. And what I love is that she really does see it as a preventable disorder. If we could start early, and I can share with you maybe later if we have time, why I think I wound up with osteoporosis. And it all started before I was 30. So a lot of bad decisions made as a teenager and in my early 20s. This is a slide, maybe you've seen this other times with other presenters. You don't see this in a Dexa scan. This would be what you would see if there was a bone biopsy done, you know, that kind of thing. But it's a really great representation to see what's going on in the bone cells themselves within that structure. So on the, let's see if I can use my cursor. Here we go. So these plates and rods that I'm moving my, you know, you can see them here. They, you know, as they become more space between them, that's where it's kind of obvious to look at this picture. That's where the more Swiss cheesy it looks, the more we're likely to have a bone not able to withstand a fall without fracturing. And a fracture and a break are synonyms. I've had a few people who think that, you know, no, I've never broken a bone, but I've had a couple of fractures. So I love this. And let me just move this out of the way a little bit. I love this painting by Georgia O'Keeffe. It's actually a pelvis. And the title of this piece is called Pelvis in the Distance. And it really looks to me like this pelvis is just gliding across the New Mexico desert. And it speaks to how bone is a living tissue. It's constantly renewing itself, rebuilding itself. That whole process takes a good 3 to 6 months. And that explains why whatever your intervention is, whether it's medication for some folks or a change of diet, or, you know, you decide I'm not going to smoke anymore. Smoking is one of the worst things you could do. Or beginning an exercise program, you really need to give it time to see if it's making a difference. It's when the rate of bone removal exceeds the rate of bone formation that we get the low bone mass. So bear with me here, just a few more basics. The most common fracture sites, the spine or the back, the wrist, and the hip. We're going to look at them individually. Wrist fractures, they can really be the canary in the coal mine. Somebody fractures their wrist, usually it happens outdoors, usually it's the result of a protective arm going out to try to break your fall. And we see it's called a Collie's fracture. It happens in the distal radius, distal just meaning farther away from your center. And you can see the little sign of that, you know, of that fracture there. Hip fractures, on the other hand, typically happen in the femoral neck. You can see the, find my cursor again, you can see I'm circling around it. That's the femoral neck there. This is the greater trochanter. That's where you put your hand on the top of your thigh bone and you feel kind of a bump. And a lot of people think that's their hip joint, but no, indeed, your hip is actually very, very deep in your groin. So if you ever have groin pain, it's most likely something going on with your hip. If you've got pain or of any kind of issue in that outer hip area, it's probably a bursitis or a tendinitis. I just thought I'd throw that in there. Hip fractures are the most potentially life-threatening. The Bone Health and Osteoporosis Foundation, which was formerly the National Osteoporosis Foundation, they've gone through a branding change within the last couple of years. They talk about how 20% of people die within a year. You need long-term care. You can't walk across the room without a walker and so on. And so some of these, and it is true, those are facts. However, what they don't state clearly is that the people who have that response to a hip fracture are almost always very frail to begin with. Bones break and bones heal. If I had the unfortunate incidents of breaking my hip, which I don't think is going to happen anytime soon, hopefully never, I'm going to recover from that because I'm in pretty good shape. It's the people often in assisted living facilities. They haven't been getting about a whole lot. They wind up dying of pneumonia or blood clots, that kind of thing, not the actual hip fracture. So the vertebral compression fractures, the spinal compression fractures, sometimes called a wedge fracture, are the ones that happen in the front of the backbone. So this keep losing my cursor. Here we go. Where you can see this kind of nasty looking break here. That's the front of the backbone. You can't put your hand on that part of the bone. In the back here, where these little bony protrusions are, those are called the spinous processes. Those are the bumps you feel. You can easily feel them in your neck, depending on, you know, how much muscle and soft tissue you have over your back. You can often feel and see it all the way down somebody's back. So they're really actually fairly common in people with osteoporosis, 50 years old. 40% chance of a vertebral compression fracture in her lifetime. Most of them are clinically silent, which when I read that paper way back when, I looked at it, it's like, wait a minute, what? You know, how can that be that 2/3 of these fractures are often not felt by the person who has it? It's usually discovered on a chest x-ray or something like that. So it's not that they don't ever hurt, but most of the time people don't realize that this has happened to them at all. What they do find over time, if you have multiple compression fractures, is that you wind up getting shorter and potentially a lot shorter. So 2 inches or more of height loss is pretty much always a compression fracture. Some studies say 1.5 inches. Most agree on 2. And many times I was working with somebody now who got a compression. I had never met her before. She called me because this happened. She bent over with very bad body mechanics from her description to pick up her cat, and she got a compression fracture. So it's really, honestly, all about prevention. And that's not the scope of this particular talk. Hopefully I'll get to come back and talk to you again sometime about, you know, some of these things and how to prevent them. But right now we just want to understand what's going on with these Dexa scans. And by the way, the International Society of Densitometrists want the abbreviation to be DXA as opposed to DEXA. So just a minor little detail, but thought I'd throw that in there. All right, some of the basics here. It is considered across the board to be the gold standard. It stands for dual X-ray absorptiometry, and it just means 2 X-ray beams of different energies are aimed at the region of interest of the hip, the spine, and so on. The bone mineral density is really what they're talking about, is how many minerals, how much calcium is in this little section they're looking at, how much magnesium, how much of all these different minerals that our bones are actually repositories of. It gives us some good baseline information. Very low radiation exposure. I have a slide about that in a little bit. We'll get into a little more detail about that. 10 to 15 minutes. The last one I had was less than 10 minutes, fully clothed, just no zippers, no metal. And they typically scan the lumbar spine. So L1 through L5 is the 5 lumbar vertebra, and they always do L1 through L4. We'll talk about that in a moment as well. Usually only 1 hip, and the forearm is scanned if you have a hip replacement or if any other artifact, which is, you know, any kind of hardware that might be like from an orthopedic kind of surgery, or in the case of hyperparathyroidism, which is an interesting thing we might get into a little bit. The thoracic spine, which is where your ribs attach. So the thoracic spine begins pretty much right behind your collarbone, and it goes all the way down to your waist, and that's where your ribs all attach. And that's often where compression fractures happen, but they don't scan it because the ribs are in the way, the sternum, which is the breastbone, is in the way, and all of those internal organs like your lungs, your heart, and so on. It prevents that good view. What does a T-score mean? So, you know, it's really comparing us to someone who's much younger than us and very healthy. So a T-score of -1 and above is a healthy bone mineral density. -1 to -2.4 the low bone mineral density. And I put the osteopenia in parentheses because, again, the International Society of Clinical Densitometrists don't like that term. They want it to be called low bone mineral density. But once a term gets in the lexicon, it's really hard for people to stop using it. So it's not a big deal. It's just, I try to stick with that former word. And anything below minus 2.5 is considered osteoporosis. So it's comparing you, as I said a moment ago, with what's typically expected in a healthy young adult of your gender. So about 30 years old, that's who you're being compared to. And it's the number of standard deviations above or below that average. This Z-score is comparing you to someone of your own age, your own sex, your own weight, ethnic, racial origin, but it's usually only used for younger people, men who are less than 50, and people with secondary osteoporosis, which means maybe somebody has diabetes and now they also have osteoporosis as a secondary diagnosis due to the diabetes itself. So how often should you have this? This has changed. I mentioned I had my first one at 50. They never do that anymore. Women, they want us to begin at 65 or beginning at age 60 in the presence of some of these other risk factors. And by the way, you have all of these slides in the handout that Shelley gave you, because I didn't want you, having to take a million notes. Family history of osteoporosis. You've had many fractures before. You've been on steroids. I was working with someone years ago. She was in her upper 40s. She really had terrible osteoporosis because as a child, she was on steroids for asthma for years, and her bones are a mess. Steroids, prednisone, is a miracle drug. If you've ever needed it for something, it really kind of solves a lot of problems, but it comes with a whole host of pretty nasty long-term side effects. Men, they want to begin at age 70, or again, in higher risk men between 50 and 69, and you repeat it every 2 years. Unless there's a like if you really get a pretty good score, you're over 65, you don't have any of these other risk factors. Many times they're saying wait 5 years, come back in 5, and we'll check again. So that's the guidelines by the Center for Medicare and Medicaid. Here's the slide about the radiation. I know, many people are very concerned about radiation. We're surrounded with some degree of radiation just being outside. So this is the breakdown. You can see how it goes from 1 sievert and then to the microsieverts. A Dexa scan is 5 microsieverts is what you're exposed to, much less than a standard chest x-ray, much less than a mammogram, or some of these the airport security screening, we're exposed to radiation there as well. So here's what the densitometer looks like. It's usually from a company called Lunar or Hologic. That should be stated on your scan. It's supposed to be. That's part of the guidelines that they all receive. And these next few slides, I think, are really important because these fundamentals of positioning, this is where sometimes things can go wrong. I've had that experience myself. Maybe we'll see how we're doing for time. I can tell you my story about that. The lumbar spine is scanned first. Many times the legs are put up on that block, like you can see in the lower picture, because the thought is that it tilts your pelvis back a bit and your lumbar spine gets closer to the table. So if somebody had a really big curve in their low back, a hyperlordosis as it's called, a good technician would notice that, put the legs up on blocks, and they're going to get a better scan. It's not always done though, so I don't want you to think something is wrong if your legs didn't get put on blocks. The line that goes down the middle of the table, this central line, you're supposed to be lined up with that. So your spine and that line should be pretty much in the same location. And it should be scanning the lower part of the 12th thoracic vertebra. So again, we have 12 of those where the ribs attach. We have 12 ribs, so 12 thoracic vertebra, 12 on each side of the ribs. And the upper portion of the 5th lumbar vertebra. So you're getting L1 through L4. The 5th lumbar vertebra is not included because it's too close to the sacrum, the pelvis, and it can make for a scan that doesn't come out as clearly. And we'll see in a later slide that the interpreting radiologist will number the vertebra and they get outlined so that they can see things more clearly for subsequent testing. A vertebral fracture assessment, many people I talk to have no idea what this is. It really should always be done if there's any suspicion of a spinal compression fracture. Happens if it's the same Dexa scan table, the person turns on their side, and now you get this vertebral fracture assessment done. And some of the considerations, first of all, as I just said, it can be performed at the exact same time. You don't go back for another test. It shouldn't be used to diagnose a compression fracture, but it really is great for imaging. It has a proven ability to detect these things, which, as we said a moment or two ago, most happen without a fall. Most are silent. When you get the this type of scan, it's much less radiation than if your doctor said, you know, I want you to come back and we're going to do some spine films, some x-rays. Lateral is just looking from the side, because that's the way you would detect a compression fracture, is from a side view. And it's much less costly to the insurers, but there are a lot of reimbursement issues. So once again, many things come down to money. And so maybe that's why a lot of people haven't heard of it, because a lot of facilities don't even include it in their regular testing. The fundamentals of positioning for the hip. So the legs have to be straight and flat on the table. And they use these blocks, which you can see if you look closely. I think the top image is slightly blurry, but they keep the legs rolled in. So it's called internal rotation. It's kind of that pigeon-toed position. You want to have between 15 and 25 degrees of that. And the reason for that is when the legs are positioned like that, you get a much better image of the femoral neck. The femoral neck is part of that upper part of the femur, which is your thigh bone. It's not your neck. So a lot of people think, oh, my neck, why do I have osteoporosis in my neck? It's not they never scan your neck. It's the hip that they're referring to with the femoral neck. And that's where a lot of hip fractures happen. And that's why they always include the femoral neck as for a particular imaging. So some examples of common hip positioning errors. I found this study really fascinating. So if we look at A, this one all the way over on the left, you can't see the femoral head. So here's your feet. Oh, what did I do? Here's your femur, the thigh bone. Here's that greater trochanter that bumps out on the side, and then it angles in. That's your femoral neck. And then the little ball that fits into the bottom of the pelvis forms the hip joint. You can't even really see it. When you look at B, that leg is adducted, which just means it's too far into the center. The leg is way into the center. That's not a good view. The one in C, it's too far out to the side. These things should never happen. The technician should be, put your legs like this, put your legs like that. You don't know what to do, but they know what to do, and you should be positioned. The last one here in D, all the way over on the right, they didn't rotate the leg enough so you can see this bump right here. This is the lesser trochanter. So you got the greater, and you've got the lesser. We don't really want to see that guy, and we're not getting the optimal view of the femoral neck. So that's a pretty clear, that came right out of this study here that I cited, examples of how things can be not done right. Why is only one hip typically scanned? Well, I think that's a really good question. There is controversy about that. The assumption out there is that there should be good correlation. Whatever's on the right, we're going to see the same thing on the left. But Peter Schwartz from Denmark did a study where he found up to 9% difference, and that's huge. 9% could be the difference between your doctor saying you really need to go on medication, or, oh, you're doing great, keep up whatever you're doing, and maybe things aren't so great, and you want to know that because maybe you'll add to the exercise program, or that you're doing, or you'll make some important changes. The thought is that bilateral, which means both sides, bilateral hip measurements should always be done on women who are 65 or older. And I've had many Dexa scans, and only one hip is ever done. And when I question, I get like the shoulder shrug. So what can I say? Here's what the report looks like. Now, lately, when I ask people to share their report with me, all I'm getting is the radiologist's written interpretation, which is basically the T-scores. But I love to see these other, like the graph where you see where you fall in the green, are you in the yellow, are you in the red? I also wanted to show you this slide because here on the hip slide, you can see, so this big box here, that's the total hip measurement that you get. But right here, this nice long rectangle, that region of interest is the femoral neck. So you're getting the two scores, the total hip and particularly the femoral neck. And over on the right, you can see how they've outlined, you can see it clearly in yellow, the outer edges of the vertebra, so that in a perfect world, which we'll get to shortly, we generally don't live in, the radiologist will be able to compare one scan with the other and really can see if things are lined up properly. And then there's the forearm scan. So if you have a hip replacement, or you've got any kind of hardware in the spine, scoliosis in the spine, especially in advanced scoliosis, you should always get a forearm scan done as well. So it's in the presence of degenerative disc disease, which is basically arthritis in the spine. Those things can make your Dexa results look better than they might actually be. So they like to do, they talk about the importance of doing an X-ray for comparison, just to make sure about the concern about potential arthritis in the spine. But once again, precise positioning is key. So they put this template down, the forearm is lined up with that. And it's so that if we're going to bother getting these tests, and the hospital or clinic, wherever we are going to bother doing it for us, we want it to be right. And the non-dominant arm is always used, or supposed to be used. Well, here's a fascinating study. I always knew that you're supposed to avoid supplementing with calcium within 2 days of getting your test. Well, this study, they actually took a calcium supplement and they taped it over the lumbar, where the lumbar spine is. So, we know what the landmarks are, where the lumbar spine is relative to the front of the body. They taped it, they did the Dexa scan, and they found that it had a substantial effect on the result of the test. In one instance, it was a 12.6% difference in one vertebra. So if you haven't heard that before, don't take calcium before you get a Dexa scan, 2 days before. There's something called diagnostic discordance. And what that means is when there's a discrepancy between the bone mineral density between tested sites. Minor discordance means you've got osteopenia. I've got to change that to low bone density in one site, and normal, so either low bone density or normal, and then osteoporotic at another. So you're seeing one thing here, another thing there. It's pretty common. You see it almost in half of the cases. But a major discordance is when you're perfectly normal, let's say at your spine, and your hip shows osteoporosis. That would be a red flag, and it could be an instance of maybe there was something maybe with precision with the way the test was done. At any rate, it kind of sets up a, maybe a little bit of not an alarm bell, because it's not the end of the world. It's just, this is weird. We need to check into this. You don't just let it go and breeze over it. So 4 out of 10 people demonstrate either minor or major discordance in their T-score. And it could be, let me just open this whole thing up, because of physiological reasons, meaning the turnover in your spine where you've got trabecular bone happens faster than the turnover that happens in cortical bone, where we see more of that in areas of the hip. So usually when someone, like a first Dexa scan, the spine numbers are not going to be as good as the hip numbers. That was the instance for me. And it's pretty typical of what we see. But it also could be maybe something wasn't done properly, as I said, or somebody has arthritis of the spine, so the numbers aren't really accurate. And the takeaway, the trabecular bone is metabolically more active, higher rate of bone turnover. It's typically lost sooner. And we've got more of that trabecular bone in the spine. And that's why we often will see that earlier loss in that area. So the problems with quality control, this is very disturbing to me. I've cited only 2 out of several that I have in my file that I call supporting evidence. I've got all these categories of things related to osteoporosis, and in the Dexa scan category there I have several articles that talk about how common these errors are. The bottom scan, I mean, they found that out of 113 spine and hip reports, 61 hips and 94 spines had incorrect positioning. I mean, that's completely unacceptable. And again, can lead to either people being treated when perhaps they don't need to be, or maybe there should be an intervention that's not being done. The International Society of Clinical Densitometry, they say that their scanners should be tested every week, every single week, and then you make your notations on a log that anybody should be able to see. It's like going in an elevator and you can see this elevator, was tested on this day and it's due for testing again, at such and such a day. So, here, and I'm not going to read all of this, you can look through it a little bit later. The precision error, though, here, the idea of that is we're human. Nothing is always exactly perfect unless you're part of a clinical study, which I was down at Penn. And when I had a Dexa scan done there, they actually had a ruler and they're measuring how far, each part of me was from the edge of the table. And they were measuring with these, it's called a goniometer. It's almost like a protractor, the internal rotation of my hips. It was so precise. And that's just, they're generally eyeballing it, which should be good enough in someone who's been trained, but they allow for a certain amount of error with any test. No test is perfect. But the concern is that it's just maybe happening more than it should be. What they want is that you have that your testing done on the same machine with the same technician, which it was like, really? I mean, I don't know when that ever happens. It's never happened with me. I know the same machine, but in the same facility. But if you can't do that, they say, okay, same machine, different technician. And this is, in order of preference, different machine within the same facility and the same technician, and followed by the worst case scenario is a different machine in the same facility and a different technician. So the Dexa scan results are used to make clinical decisions with your doctor. The femur, either the neck or the total hip, is the optimal site for predicting the risk of fracture, but the spine is what they will often use to see how you're responding to treatment because of that greater turnover. So you'll get a better idea of how this person is responding, whatever the intervention is. And for diagnostic categorization, the lowest score is used. So you're not supposed to use, like, if L1 through L4, everything is pretty good, and then you have one that's so far off, like it's minus 3.5, and everything else is in the low bone density range. They just discard that number. That's what they're supposed to do. But still, if your spine is low bone density, your hip is in the osteoporosis range, you're considered to have osteoporosis. But they don't want a diagnosis of osteoporosis to be made based on the bone mineral density in someone who's had a number of fragility fractures. And the crazy thing is that the vast majority of people who experience these low trauma fractures are not in the category of osteoporosis. And so the conclusion of this study, and this is a quote that you can see here, is that they want lifestyle changes to be the targeted effort, which I thought was like, hooray, finally, we're talking about that as opposed to just the medication. And this author here, I forget how to pronounce his first name, but his last name is Garvan, and he's from Finland. It's one of his biggest fans, because when he writes something, and it's always in the British Medical Journal, I always learn so much, and it's like he's got no conflicts of interest. He wrote an article called Osteoporosis, the Emperor Has No Clothes, that was published in the Journal of Internal Medicine, not the British British Medical Journal. And it's a fascinating article. It's just very eye-opening. So just because you have low bone density doesn't mean you're off the hook and you don't need to, watch your diet and exercise properly and so on. I think DEXA scans are a blunt tool. That's my opinion. They don't measure the bone quality, and your bone strength is a factor of bone mineral density and quality. The bone mineral density is only one part of the story. It's a two-dimensional measurement of a three-dimensional structure. And then we've got those issues with precision to be concerned about. The problem is, once a procedure becomes routine, it can be difficult to replace. And a lot of money has been spent on putting these machines in different facilities. So I think we just have to get better at using them. X-rays aren't used for screening, because if you see osteoporosis on an X-ray, you've already got 30% bone loss. The trabecular bone score, and I'm just going to go a little bit faster here because I realize it's about 7:45, and I want to make sure I get to everything and all your questions. So this was introduced in 2008, and it's software that gets installed on the Dexa computer. So it gives you information about the microarchitecture. It's like a textural image. It's very interesting. And it does tell you about the quality of your bones. It's only used at the spine. It can be done retrospectively on archived images. No additional scan time, no additional radiation. It's not affected by the degenerative changes at the spine the way you can get with the regular Dexa. And it was approved. It's finally covered by insurance. So that happened earlier this year. And it's important because before, remember I showed that slide in the very beginning where, this is normal bone and this one looks like Swiss cheese. So that's the microarchitecture. And usually we had to actually get a biopsy of it. This is a way of non-invasively really looking at that bone microarchitecture. It's very well accepted now. It's, all over these different peer-reviewed journals. And it's really considered that getting your trabecular bone score, the TBS, the bone mineral density, looking at all the clinical risk factors, the FRAX score, the Garvan calculators, which we'll talk about in a moment, that's where you're going to get the most comprehensive overview of a person's bone health. So, for example, if you've got arthritis in your spine, it might show a higher bone mineral density on your DEXA scan, but the microarchitecture could actually be pretty bad. And so the trabecular bone score would indicate that. And it's especially useful when someone's just kind of in that borderline range. Michael Luecki and Andrea Singer, I was listening to this was a virtual presentation at this meeting earlier this year. And I put the no single test is perfect in quotes because that's what Michael Luecki, he's in New Mexico. That's what he said about this test and every test. It's like, we've just got to kind of look at the big picture with as many different tools as we possibly can and not put all our eggs in the Dexa basket, the gold standard. We need to really look at more than that. Here are the values. You can see this yellow on the right, this image. That's what it would look like if you got the report back. You can see all these little just textural images and the normal, partially degraded or degraded bones. I gave you the scores there if you have a trabecular bone score in your medical record. You can go back and check. I'm sorry, I forgot that this is in Pennsylvania, a Pennsylvania crowd. So I went to metamapsgroup.com. These are all the places you can make sure that TBS is done, but you can check out for yourself. Go to this website and see if where you usually get your DEXA scan, if they include the trabecular bone score. So these assessment tools, the FRAX and the Garvan risk calculator, it's not as commonly done, give us more information. As I said a moment ago, the FRAX, which you can, I think there's an app for that. It calculates your 10-year probability of a major osteoporotic fracture, the hip, the spine, the wrist is actually included in that, and all of these other factors to determine your incidence or your chance of getting one of these fractures. It's built into the software, not meant to replace clinical judgment. It's just another tool. They don't use it in younger people or if you're on medication. So if your score is 3% or more, they consider you at risk of fracture. So they're really using this to help determine treatment. There's actually a good amount of controversy about the FRAX score, but I won't get into that. This is what it looks like. You get this kind of, there's many countries that do it. So you see the American flag there. They put in your weight, they put in your height, and then all these questions are answered. You can go online and do it yourself. It came from the World Health Organization. And the Garvan, which comes out of Australia, I think it's a little more interesting because it includes a history of all fractures anywhere, a fracture of your foot, a fracture anywhere at all is included to give you that fuller picture. But it also they talk about a skeletal age. So it's used, this computational model, to calculate somebody's skeletal age, putting all these factors together. They say it does a better job at identifying people at risk of that first bone fracture, tends to overestimate the hip fractures. But I wanted to get to, here we go. So, for example, a healthy 70-year-old man who sustains a hip fracture now has a skeletal age of 75 based on the Garvan computational model. And then if he goes ahead and has another fracture, unfortunately, now his skeletal age has increased to 87. So it's really just a different way of kind of looking at somebody's bone health picture. The REMS, more commonly known as Echolight, I don't know if any of you have heard about that. It's used all over Europe. It is approved for use in this country. I only know of one place in Jersey, in New Jersey, that's doing it. I don't know any place in Pennsylvania where it is. This is actually a picture from the REMS, the manufacturer's website. It kind of looks like an ultrasound if you've ever, had a baby and they're just kind of looking at the fetus. Same thing. She's going right over the spine. They go right over the hip. It's very quick and it's considered very accurate. My thought why it's nowhere around here with all the huge medical facilities we have in Philadelphia, and you all as well in Boston, is because the Dexa scans are already there, the Dexa machines. That's just my opinion. It's portable. You can do it in your doctor's office. It's much less likely to be done with those precision errors. You get the results in minutes. It's so cost effective. But anyway, so keep your ears open for that. And the takeaway is that our bone health is really about more than just bone density. I'm not saying it's not important, but we really want to look at the big picture. It's one piece of a very complex picture. And with 5 minutes to spare. So hopefully I didn't talk too fast at the end. I actually deleted earlier before I sent Shelley the handout so many slides because there's just always so much to talk about. So I could stop sharing the screen and we can open it up to everybody.
Sure.
Shelley, is that what you want to do?
Great. That would be great. Before we do that, I just want to say, excuse me, how much I've enjoyed this today. And I know that everybody has as well. So I don't think I'm alone in that. And you've brought to light so many interesting points. I had never heard of the Garvan. I don't know if anyone else had. Of course, we have heard of the Echolight, but yes, just little snippets of it. And I think we've all been frustrated by being turned away from by our practitioners about being able to get the trabecular bones service, TBS, trabecular bone score, determined, and knowing that now that it has now been passed that we can all request it is helpful.
Yes.
So
the problem that you might face, and which is happening down here, is that if someone goes to a place where they weren't doing it before, and now they're going to say, well, we can't come, it's going to be apples and oranges. You really need to start in the same place. It really is baloney, I think. So you start wherever you start with the TBS, and let's just begin from there. And, it's if there's a test out there that can give us more information to help make the right decision about how to move forward with our bone health, then we all should have access to it. And I think from a grassroots level, when people, I gave this talk last year before it was even covered by insurance, and people were calling the radiology department of Jefferson, of, you know, of Lankenau, all these big hospitals around here, Abington, and they're saying, I want the team. Why don't you have it? Well, I'm going to go to Penn then. I'm going to take all my records and I'm going to go over there. And things are starting to change because it's all about money. I mean, in fairness, you know, they have to make money too. They've got to pay for all these services and they don't want to lose us. So if we call and we ask and why not? You know, why can't you get it? I mean, they have to pay for it. They have to pay for the software to install it's not free, which, you know, might be the hurdle right there, but
isn't that Echolight quite promising? That sounds very
yes,
exciting.
absolutely.
Well, you certainly have so many fans here already. Let me just go back to some of these questions. And one of the first ones is, would the doctor need a diagnosis code to order a TBS test?
No, it's done at the same time. It's not a separate test. So you go for your Dexa scan when you're due to go. It would happen at it automatically gets spit out if they have that software installed.
Okay, great.
Yeah.
Excellent. Okay, and could you share how you did help reverse your bone loss? Because you did bring that up in your
yes.
Yeah.
So first of all, when I was a teenager, I smoked. True confessions. Stupid girl. I didn't exercise. I drank a lot of Pepsi. So I think that did it right there. You know, I went into my peak bone density, which is in your mid-20s, in a deficit already. So, you know, the peak bone density is, you know, once you've built all the bone you're going to build, that's the money in the bank, and you can't put more in, you're just trying to keep it at that level. So, you know, having said that, I got my vitamin D checked and it was really low. And so I started supplementing in vitamin D. I don't do that anymore because it's at a satisfactory level and we check it every once in a while. Lots of controversy about vitamin D also, another talk. But the research, so I walked, I ran, I did crunches, which is not going to build the spine density. All the reading that I did so much from Rashid Sanaki at the Mayo Clinic. It's like, you've got to do back strengthening exercises where you're lifting your upper body into extension. So you're not going forward, you're going in the other direction. So I added all of these additional exercises with more weights than I was kind of really coasting along at a lower amount of weight. And I stopped drinking so much milk. I think I was drinking a lot of milk, and because I like milk, and I thought I bought into the whole milk mustache thing, which was all funded by the Dairy Council. I mean, I'm a healthy skeptic. I am not a conspiracy theory kind of person, but, you know, I have learned to follow the money. And so many of the reports about how great dairy is for you is funded by the Dairy Council. So anyway, I stopped. I still drink milk, but if I have a cookie, I want a little bit of milk, but I don't drink glasses of milk anymore. And gradually, I think it just made a difference. I also wonder, maybe the scan wasn't right with all this additional research I've done. Like, we'll never know.
I know. Well, they say there's, a significant lack of calcium absorption from milk versus yogurt, for example, of how much you're actually absorbing. So I can see why milk was something that might be
the interesting thing about milk is it has something in it called D, like dog, galactose. And D-galactose is a breakdown of the lactose in the milk. And I'm such a bone, like this is what I've stopped reading novels, and this is what I do with my coffee in the morning. I read all these things. D-galactose is used in laboratory mice to accelerate the aging process when they're doing longevity studies. I was like, holy, you know what? It's like, oh my gosh. So, now that's a controversial statement, but it was enough to kind of put my antenna up and think, maybe. Oh, and the other thing is the countries, and this is a statistical fact, the countries that consume the most dairy have the highest rate of hip fracture. Highest rate, including the United States, Austria, Switzerland, all of those Scandinavian countries, they're way up there on the list. And yeah.
Interesting. Very interesting.
I can go on and on, so I'm just trying to go to the next question.
Okay, the next question.
I get very excited.
Oh my goodness. You mentioned no calcium from Barbara 2 days before your Dexa.
Right.
And so you would refrain from consuming milk as well, the dairy products?
No, it's the undissolved calcium tablet,
okay.
The potentially undissolved calcium tablet that could be in your GI system somewhere. And so that's going to, if it just so happens to be right over one of those lumbar vertebrae, it's going to skew the result.
Okay.
Seems kind of far-fetched, but the studies are there.
I know. I couldn't believe the one you stated where they put an actual calcium supplement.
I know.
On top of them.
How cool is that? It's like, how are they even going to test it? And so they just took it and they scotch taped it on the person.
It seems impossible, but that's interesting. Okay. How frequent are femoral neck fractures, and are they more often stress fractures?
How frequently do they happen? I mean, it's a pretty common fracture that it often will be from a sideways fall. But they're not uncommon. But I talked about fear in the very beginning. The worst thing somebody could do is not get out and exercise, not go for that brisk walk, not lift those weights. And, you want to follow the guidelines. Maybe we can talk about exercise another time, the specifics of it. But many times it's the being of, well, if I do this, I'm going to break something. And then people do nothing, and it becomes this downward spiral.
Because
so I know I talked about.
Yeah, I'm sorry, go ahead.
No, I know I talked about those fractures, but it's because that's why we're all here, because we don't want to break a bone. So I just wanted to kind of lay that foundation of the bones we're most concerned about, and then how the DEXA scans are looking at those particular bones.
Did you, one question that you had addressed the fact that not only were you drinking a lot of milk, but you were also walking and doing a lot of running and that sort of thing. Did you continue to do those things as well? The running and the walking?
Yeah. Yeah. Walking has not been found to make a difference in bone density. But what it does make a difference is lessening the incidence of hip fracture. So the regular walkers, and there are studies about this, it's really interesting. People who are regular walkers, hopefully not a stroll, but a nice clip, you get out there, you walk maybe 30 minutes every day, are far less likely to ever sustain a hip fracture, even though their bone density test might not show any significant changes. And it kind of comes back to, we're putting all our eggs in that basket, but maybe your bones are stronger than the DEXA scan kind of leads you to believe. It's not always that clear. So you need to do some weight lifting with weights and particular exercises, but walking has been found to make a very big difference for people.
Thank you. So helpful. Also, I see one last question here. I don't know if anyone else has anything else, but this one is, what is the test that you said could be done retroactively? I don't remember.
The trabecular bone score.
Okay.
So they could take a Dexa scan that you've had before, and I don't know how they do it, but they can somehow with the computer program give you the TBS score at the same time.
Very good. Someone else said
The QCT. So that's the quantitative CAT scan. Usually it's a peripheral quantitative high resolution. So it's usually the P, HR, whatever, CT. It's a little bit more radiation. It's very, very accurate. They only use it for research. It's very rare. I've actually never heard of it being used to monitor somebody's bone health or even their response to any kind of testing.
And I guess I'd like to just close with this question. I'm just wondering, you had mentioned that, you yourself have trouble obtaining some of these tests. And I know many of us have had those issues as well. How do you approach your own endocrinologist, Joanne, when you want to obtain some of these extra services besides their bone density, or perhaps even a bone density test that is only recommended to be received every 2 years, but you'd like to receive it once a year? But could be TBS or whatever it would be.
Right. It's very frustrating. I mean, I like my doctor, but so just very quickly, I kind of alluded to this earlier in the presentation. I had a Dexa scan, and I'm going to say this as fast as I can. I got up on the table, and I'm on the edge of the table because, that's where I landed. And I knew I needed to get in the middle, but it's like it all happened so fast. I'm thinking, I'll wait and see what she says. And she never told me to get in the middle. So there I am at the edge of the table. I mean, I could have fallen off. I'm like right on the edge. The central line is lined up with my right arm. Not a word. And I was being very devious, but it was like my own little study. The legs weren't rolled in properly. Long story short, the report comes back, and I was positive they were going to say, you need to come back in. We need to redo this test. It wasn't done right. No, what happened was, you're so much better now. It's almost normal. It was minus 0.1 or whatever they said. I mean, whatever it was very close to 0. And my doctor is calling me. This is so great. And I told her what happened. There's like silence on the other end. She didn't know what to do with me. She didn't know what to do with someone who was asking all these questions. And I'm not an aggressive person. I was just being very low key about it. So I called the head of the Department of Radiology at this hospital, which is a big hospital. And he listened to me, and I said, look, that there needs to be better quality control at this facility, because other people would not have necessarily known that this wasn't done right. And he listened to me, and he said that they would certainly take care of it. And I have no idea what happened, but it was just so emblematic of everything I had read.
Sure.
And that the interpreting radiologist didn't look at it and say, well, this is a
yeah.
So
how would this have happened?
What's with that?
Yeah.
I was so discouraged by that. Yeah. So I doesn't really answer your question.
No, you did. You absolutely did. I think that we all are frustrated by that. And I think just knowing that one thing that we all need to do is take initiative and say what we think. Oh, I think your screen.
Everybody's in a hurry, and that will, yeah.
Joanne, we're losing you a little bit. Sorry.
Freeze.
Well,
Yeah, sorry. I
that's
saw that.
okay. That's okay. We got you for a whole hour. We're thrilled. And, we would love to have you back.